All right. So we have a few musculoskeletal disorders that we're going to cover. And like I said, this is going to be your favorite shortest lecture because this is really straightforward and easy today. So we'll go over those and we will then be done with the class. We're not going to take a break today. So types of unless anybody needs a break. Does anyone need a break? Okay. So we have several types of musculoskeletal disorders. We have soft tissue injuries. And that's going to include your joint capsules, your ligaments, your bursa. Those are your kind of inert soft tissue injuries, things that don't move. And then we have contractile soft tissue injuries. So that's your muscles and your tendons. Those are the parts that actually do move. And then we have bony injuries, fractures, dislocations, infections of the bone. We can have bone cancer. We can have bone structure disorders. The bone actually grew improperly. Or it is weakening, so we could have a progressive osteoporosis. And we can have neurologic musculoskeletal disorders. So ligamentous injuries. Again, we just said a ligament is this dense connective tissue that is kind of stabilizing bone to bone. And we can strain it. We went over the grades of the strain, grade 1, grade 2, grade 3. You're going to want to know this. Is essentially classified by what is the extent of the injury to the ligament. Grade 1 is you've stretched it, but it's not unstable. So you could have a lot of swelling. You could have a lot of bruising, but if the joint is stable and there does not appear to be an active tear in it, that is a grade 1. Grade 2 is more moderate, and this is you have in some degree of instability, but the majority of the ligament is still intact. So you could have a little bit of a slide, but it looks like, you know what, it's still intact. It's not sliding a whole lot. A grade 3, which is a severe, is going to be a complete disruption. You've completely torn that ligament. Somebody who has a medial collateral ligament tear in the knee, an MCL tear in the knee, if you do you put your hand down here and you hold their leg and you put pressure, their knee is actually going to flex sideways and open up. So it's going to tell you, hey, that is actually completely torn, because if that ligament was intact, it would stabilize the knee sufficiently that you couldn't do that. So a lot of times what we're doing with the knee is we're actually taking people who are already in pain and we're shoving it to see, does it bend this way? And it's really kind of mean, but it's the only way that we really have to see how injured is your ligament. Is it a little bit torn, like it hurts like heck when I do that, but it's stable? Or is it so torn that I can actually just push your knee right into the side? So we would do it both for the inside medial ligaments. For the outside, we would do the maneuver the opposite way when we're testing the anterior cruciate ligament, which is the one that's inside your knee stabilizing. We're using a drawer test, pulling backwards. Say it again.
Could you say that one more time?
So medial collateral ligament, you're going to be pushing from the outside of the knee to see if it opens up inwards. On the lateral collateral ligaments, you're going to be pushing from the inside of the knee to see if it opens up outwards or laterally. And with an ACL tear, anterior cruciate ligament, you're going to grab the entire knee and slide it forward and see if it draws, and then push it back and see if it draws. All right, so here's the ACL injury. I got a little ahead of myself. So you can see that the ACL is situated right smack in the middle of the knee. This is your big stabilizing ligament. Very, very common injury among athletes, people who jump and twist. So the kind of mechanism that you'll usually see with this is someone will come out and they'll be like, I was playing basketball, I jumped up, I came down trying to catch the ball, I twisted my knee, I heard a big bang pop, and I fell on the ground. That's your classic ACL tear. Most people who have an ACL tear will say it sounded like a gunshot. It was a big pop. It is a big bang. It's a big thing. So if you hear that type of a story, you want to be very suspicious that this is an ACL tear. Having said that, you don't instantly rush out and MRI everybody who has a potential ligament tear. The general rule of thumb is we stabilize you, we put you into a leg immobilizer, we put you on crutches with maybe touchdown weight bearing, and then we have you follow up in a week or two to see how unstable is that joint. And at a month, if it's still unstable, we would MRI and look to see, do we need to do surgery? Generally, you're going to be using MRIs not because you're curious, and you want to know about the injury, but you're using it to evaluate whether or not that patient needs surgery. Do they need physical therapy? You can diagnostically evaluate the patient and determine they need physical therapy just on the basis of pain and disability. You don't need an MRI to tell you that they need physical therapy. The MRI really is differentiating, do they need surgery? So joint capsule injuries. This, again, as we know that joint capsule is part of stabilizing our synovial joints. We can have injuries to the inner membrane and to the outer membrane. The interesting thing is that when we get injuries to these are poorly vascularized areas to begin with, so they don't get a whole lot of blood flow, which is why injuries to joint capsules can really take such a very, very long time to heal, especially cartilage. Cartilage does not have good blood flow to the area, so if it becomes inflamed, it's going to take forever for that inflammation to go away. So we can actually injure either the inside or the outside just on the basis of wear and tear, repetitive injuries, even acute traumas. You hit it and you traumatize the joint capsule. Fasciitis and bursitis are two other potential kind of inflammatory processes. The fascia itself is the connective tissue sheath. It's that little plastic, if you want to think of it, lining where those muscle fibers are running through. You may have heard of the term fasciotomy. A fasciotomy is essentially you're coming up and you're snipping the lining around the bundles of the muscle fibers so that you can open it up and give it more space. You're releasing the pressure within a specific compartment. Fascia are what create compartments within our body. And these kind of like super highways where things are passing through are helpful to keep everything in place, but if you get too much pressure building up into those areas, you can actually cut off blood flow, and that's how we end up with compartment-type syndromes. And that's essentially what a compartment syndrome is we're increasing the pressure within a compartment, and we're reducing nerve impulses, and we're reducing blood flow to the area so that it becomes ischemic. Bursa, again, we said are located typically between muscles, tendons, and bones, and help to condition and cushion those areas. So when they become inflamed, they can be very painful, but they're not always super painful. Sometimes it's just they kind of swell up because they've been overworked. And we essentially treat those by just icing and resting those areas. There's not a whole lot to do. You're just going to have to wait it out and wait for the inflammation to essentially go away. Our most common areas of bursitis, elbow, that's the one that's easiest to see. Hip, you'll see it a lot. People come in, oh my gosh, my hip is killing me. That one's a lot harder to see. You might see a little bit of swelling and a little bit redness, but because we tend to have more fat in this area, it can be very difficult to actually see the bursa. Shoulder bursitis is another fairly common area. All right, so our joint capsule injuries, I think we essentially already covered this to some extent, but one of the ones I did want to point out is shoulder joint capsule injuries. So again, because joint capsules are not highly vascular, we want to be careful that we are not restricting the blood flow to that area any further. So one of the things with shoulder injuries is that immobilization can actually lead to more loss of mobility than if you don't immobilize. So you have to be very, very careful with shoulder immobilizations that you don't leave them in too long. So in the emergency department, when we have somebody who's dislocated or they've injured their shoulder, we will put them into a sling, but we'll say, you know what, you need to take your arm out and you need to do some gentle range of motion at least 4 times a day. That is helping to stimulate those joint capsules, bring blood flow into those areas, and make sure that you're not actually becoming ischemic in those areas. You can actually when the joint starts to stagnate, it's not getting nutrition into the area, and it actually starts to develop degenerative changes fairly quickly, and those can be permanent. So you can develop kind of this fixed or frozen shoulder from a joint capsule injury that you've immobilized. So you do want to just be very, very careful of that, and those are called adhesive capsulitis is what the term for that is, where you've had an injury, it's now developed adhesions, it's lost mobility of the joint as a result of it. Blunt trauma, we're all familiar with blunt trauma to our soft tissues. This compromises our contractility just simply on the basis of pain and hematomas into the areas of those muscle bodies. So we're bleeding into the belly of the muscle, therefore we can't get a proper kind of shortening of our sarcomeres. Everything's a little bit, it's just not working the way it should. So the interesting thing is I actually wasn't aware of this until I pulled up the statistics. 9 to 20% of muscle contusions can actually coagulate and calcify. So if you have a really bad bruise into a muscle area, you can actually develop calcifications. As a result of that, that can be permanent. So that was kind of new and interesting information to me. So obviously we're familiar, you injure it, you overwork it, you do too much exercise, or you hit it in a trauma and you're going to contuse that area. And treatment for this is essentially going to be rest, ice, compression, probably gentle range of motion, and if you're having significant persistent loss of mobility, you sometimes can require surgical intervention for calcifications. I haven't really seen that too much, in all honesty. Most of the time it's going away. Usually ice for at least for the first 24 hours, and thereafter you're going to be applying heat to try and help restore circulation to the area, get rid of some of those dead cells and byproducts. And when you do apply ice, just so you all know, it's 15 minutes to an hour is your maximum limit, otherwise you'll cause reverse swelling. It's generally 15 minutes every 2 to 3 hours is kind of your how often you should ice. Without direct ice application, putting it over some sort of a towel so that you're not causing reactive kind of hyperemia. All right, wound healing. So obviously we can have lacerations as well. The inflammatory response comes in. The acute phase of our wound healing is typically going to take about 2 weeks, and then we have a subacute phase that's going to take another 2 to 4 weeks. So by and large, we're going to expect wound healing in anywhere from 2 to 6 weeks, depending on the extent of the wound. Macrophages and fibroblasts are going to be involved in this process, coming in, clearing out the foreign bodies that may be there, laying down a new kind of matrix of collagen, and dividing these, developing these fibrin connective tissue sections where they're going to build new granulation tissue on top of it, and essentially just grow the granulation tissue. Lastly, we have, might not be quite lastly, we have a few more after this, tendon injuries. And these are just anywhere from minor to complete tears and ruptures, just like we would have for a ligament. It can, anytime there's inflammation in the tendon, we're going to just call it a tendinitis. Some tendinitises are due to repetitive use injuries or traumas. Some of them are actually due to infection. When you have a tendinitis that's due to infection, that is far more concerning because of the potential for long-term and chronic disability. One of the classic ones that we see in the emergency setting is tenosynovitis, where you have essentially inflammation or infection underneath one of the finger joints. And that can be actually a surgical intervention. The patient's like, I can't move my finger at all. And they're just coming in and they have this kind of red swollen finger, and you just say, okay, just let me just marginally flex and extend that tendon, and they will just go through the roof on you. Where all you're doing is looking to see, is this tendon here involved? You just marginally flex it, and that's telling you that they have an acute tenosynovitis, and that's considered an orthopedic emergency. Something that patients should actually be seen in an emergency setting for.